My name is Dr. Ohene Eshun, and I'm a medical officer with Raphal Medical Centre. Now, for this afternoon discussion, the outline, kindly give me a minute. Let's see if you can share the slides. So the outline of the discussion, we'll be looking at the structure and function of the prostate gland. We are trying to share the slides so that all of you can also. All right, thank you. So again, we'll look at the overview of the male reproductive system. We'll have an overview of the male reproductive system. We'll also take a brief introduction to the topic that we are discussing. I would also have some general tips on prostate health. We'll look at risk factors, symptoms, and some treatment for prostate cancer. Then at the end, we will take questions and attempt some answers. Okay, so with this slide, we are looking at the anatomy and function of the prostate gland. The prostate gland, in a way, forms part of the male reproductive system. Now, it is located in front of the rectum, and it's just below the urinary bladder. The size of the prostate is that of a chestnut, and the shape is somehow conical. Now, we'll look at the function of the prostate. Now, the prostate also contributes to the seminal fluid. And when we talk about seminal fluid, the semen is made of the sperm and the fluid that helps to carry the sperm. And that is the seminal fluid. Now, there are about 3 structures that help to generate this seminal fluid, and the prostate is one of them. The bulk of the seminal fluid comes from the seminal vesicles. Very shortly, we'll look at it. But the seminal vesicles contribute about 2/3 of the seminal fluid, and the rest is contributed by the prostate and the bulbourethral gland. So we've stated one function of the prostate as it's contributing to the seminal fluid. Now, another aspect of its function is that when we look at the prostate, it has muscles, and this muscles also helps to propel the sperm when the muscles of the prostate contract. Now, this is by virtue of the location of the prostate. So the next slide will give you a better view of what we are describing. So this is a diagram of all that we've been describing so far. And on this diagram, if you can focus on the cursor is moving. Now this area is the prostate. This chestnut, somewhat conical structure here is the prostate. Now what happens is that sperms are produced in the testicle. So we have the testicle here, and these sperm, once they are produced, they are stored in the epididymis. Now in the epididymis, they undergo maturation. So when a male is aroused during intercourse, now the mature sperm in the epididymis will travel through this tube. Now the tube is a little faint, but that's the vas deferens. So the vas deferens, we have it here. It travels through this tube. Now if you follow the outline of the tube, you realize that it joins another structure here. That's the seminal vesicle. So here at this point, the sperm that is produced will receive the seminal fluid. when it connects to the seminal vesicle. Now, from the seminal vesicle, you can see a tube here. Now, this tube we are looking at is the ejaculatory duct. So this one is the ejaculatory duct. Now, you would appreciate that this ejaculatory duct sort of cuts through the prostate. So it runs through the prostate. Now, what we are seeing here, another duct is also here. So we see two ducts. Now, this is the urethra. Now, this urethra runs all the way through the penis. And this portion of the urethra is what we call the prostatic part of the urethra. So the penile tube has portions. We have the spongy portion, and we have the prostatic portion. There's also another portion, but that is not so significant yet. So once the sperm is here, receives fluid from the seminal vesicle, then it travels through the ejaculatory duct. Then at the level of the prostate gives its contribution of the seminal fluid. Then together, by the contraction action of the prostate, they travel down. Now, as they come down, this gland, which is also called the Cowper's gland, the bulbourethral gland, it's also called the Cowper's gland. It also adds on to the fluid. So we have three structures here: the seminal vesicle, the Cowper's gland, and the prostate, generating fluid that will bathe the sperm and also assist its transport. So when you look at the prostate, in part, it's performing a vital role when it comes to the sexuality or the sexual function of males. I hope this diagram at least makes our description a little more easier. So now we know the function of the prostate, production of seminal fluid, and also helping in the propulsion of sperm. Now, this term will carry us or stay with us throughout the lecture. And basically, we are looking at cells. Now, two main things can happen to cells when it comes to cancer. Some of us might have heard malignant cancer and benign cancer. When we say benign cancer, they are cancers that are not dangerous. Now, the malignant ones are dangerous because they can spread. And this diagram we have here in bit explains what we mean by benign and malignant and why some cancers are dangerous. Now, this is an example of a healthy cell. We have only 3 cells. Now, when we come to the second line, we also have 3 cells, means the cell number has not increased, but the size of the cells have increased. So with this, we are looking at hypertrophy. So in our term, when we say hypertrophy, means the cell number is the same, but the size of the cells have increased. So if before it was at 2 centimeters, now we are looking at even 10 centimeters, 20 centimeters. The second term we are looking at is hyperplasia. Hyperplasia simply means the cell number has increased. So as we go through this lecture, this term should stay with us, and that will help us appreciate the lecture the more. So we are looking at the relationship of the prostate and the urethra. And once we get this appreciation, most of the symptoms that we'll describe would be related to the position of the prostate with respect to the urethra. So this is a normal bladder, and this is a normal prostate. So the gray area we have here, that is the prostate. This is a cross-section of the bladder and the prostate. And in between, we can see the urethra. Now, this is the prostatic part of the urethra. This tube that you are seeing, if you bear with me, I'll just go back 2 steps and I'll show you where exactly it is. So this tube that I showed you, that is it. If you follow the cursor, That's the tube here. That's the prostatic part of the urethra. So that is the relationship of the prostate and the urethra. Now, from the terms we described earlier, this is a hypertrophic cell. So we are looking at a normal prostate cell and a hypertrophic prostate cells. Now, what is happening is as the cells increase in size, they also impinge on the tube. They block the tube that is supposed to be meant for urine drainage. So we should also keep this picture in mind. Now, in prostate cancer, you probably wouldn't have just a pure increase in size. Most often it's even increase in number. So that would mean that it will be a combination of hypertrophy and hyperplasia of the cells. So from the diagram we saw, this is what the end product would be. Now, as the prostate increases in size, the bladder outlet, which is supposed to allow for the drainage of urine, gets blocked. And so we have a picture here where we have urine in the bladder, but cannot be drained through the urethra because the prostate has taken over the space. And most of the symptoms, as I said, will be related to this one particular picture. Now the next slide gives us a live image of a cancerous prostate. Now there's a normal prostate texture. As you can see, the cells here are homogeneous. When we say homogeneous, they have the same uniformity. I mean, you don't see any contrast. But immediately you take a cancerous cell, you can find a sharp demarcation or contrast between the abnormal cells and the normal areas. So here, even without a trained eye, you can appreciate that something aggressive is taking place over here. So there's a prostate that has started showing gross signs of cancer. Now, it's also worthy to note that when we take the most common cancers in both men and women, prostate cancer is number 4. So worldwide, in both men and women, prostate cancer is the 4th most common cancer. But when you come to men, that's men in particular, prostate cancer is the 2nd most common cancer. So I think it's very important a topic that we have to discuss. So let's look at, go straight into the introduction. We are saying prostate cancer is a male disease, mainly because females do not have prostates. Now the cancer initially may not show any symptom. So when we say asymptomatic, what it means is that the patient may not feel anything. It is very dangerous at that stage because if at least you would have experienced something, then it would alert you to come to the hospital. But most often at the early stages, you wouldn't feel anything. And the progression is also very slow. So we are saying it has an indolent course. That's a very slow progression. And around that time, even for those who have been diagnosed, what we use in the management is what we call active surveillance. So you just do watchful watching, or you follow up the patient over time. Now, the third point is saying that in Africans who are living with prostate cancer, the problem we face here is with diagnosis, appropriate treatment, and often this is due to the lack of screening. So that's a challenge we have here. In the Western world, a lot of people are very health conscious. So majority of them would have known their status. But in Africa, if you move from the city to the urban centers or to the rural centers, you realize that a lot of hospitals are not even available to start with. Even cheap compounds are not available at certain locations. So even having the idea to go, if that even comes to mind, where to go even becomes a problem. So there's a problem of diagnosis and there's a problem of treatment. I think this point we have already stated that globally among males, it is the second most common type of cancer and the fifth leading cause of cancer-related deaths in men. So if you take all mortalities in men as a result of cancer, prostate cancer is the fifth. And this is a statistic that was generated by Global Cancer Mortality, Incidence and Prevalence. So in 2018, they estimated that over 1.2 million cases of prostate cancer was in the system. So that's worldwide in 2018. Now, prostate cancer-related mortality in 2018 was estimated to be around 359,000. And if you look at it, I mean, it's quite significant. So, I mean, this topic, the importance of it cannot be overemphasized. So at this point, we have already mentioned it in part, that it's slow growing. So at the early stages, most people, I mean, wouldn't experience any symptom. Now, once you start experiencing symptoms, the prostate cancer symptoms are not so different from the non-cancerous prostate condition. So here we are looking at BPH, that is benign prostate hyperplasia and prostate cancer. But there is an overlap in the symptoms. So we should also take note of that. We are saying that prostate cancer incidence and mortality rates are strongly related to age, with the highest incidence seen in the elderly. So we'll go to another slide that will show us, I mean, the incidence. Realize that as one ages, usually above 55, the incidence of prostate cancer also increases. So we should also take note of that. Now the topic, if you look at it, we are looking at related conditions aside the prostate cancer. So the prostate organ can also have infection, which we call prostatitis. So it's not only prostate cancer or BPH, you could also have an infection of the prostate. This infection could also give you some urinary symptoms. Again, you could also have a chemical irritating the prostate, and this is more of a sterile inflammation. So the infection can give an inflammation of the prostate, and sometimes it is not infection, but something other than infection irritating the prostate, giving you more of a sterile inflammation picture. So let's look at the incidence of prostate cancer. We said that the incidence of prostate cancer increases with age, you've mentioned it, and 1 in 350. So if you take 350 men, one at the age of, that's among the 50-year age group, one will be a prostate cancer patient. Now, if you move further from age 50, that's you're looking at between 50 to 59. When you take 52 men, you would at least have one. So that becomes 1 in 52. Now, if you move further upwards, that's where it even becomes more alarming. That's among the age 65 group. When you take 10 men, 6 at least would be prostate cancer patients. And this, we are looking at random sampling. So randomly, if you sample 10 men who are above 65, the chances are that you have 6 in 10. Now, what is the cause, or what are the causes of prostate cancer? Now, the cause of prostate cancer, I mean, is still not known. They know to some extent some of the changes that will lead to prostate cancer, but emphatically, it's still under studies. So it's a subject of, I mean, numerous studies and remains largely unknown. And what we know is that some genetic mutations are responsible for the development of prostate cancer. So basically, for the aspect of genes, it is indisputable. Now, since the causes, hello, can we kindly have our microphones muted, please? Yeah, so continue. Since the causes are not known, at least we have to now focus on the risk factors, because knowing the risk factors and also working on the risk factors to a large extent will help you to reduce, I mean, your chances. So the risk factors. Now, one of it is old age, and I mean, old age is a non-modifiable risk factor. When we say non-modifiable, means there is nothing you can actually do about old age. Whether you change the age on paper, really the genetic processes will go on. So old age is a non-modifiable risk factor. I think we've spoken about age in part, but if you look at the last bullet, it says 99% of prostate cancer occur in males greater than age 50. So if you are looking at the incidence, I mean, a chunk of it is at the older age, means prostate cancer is most unlikely and very uncommon in the young. We can say it's more of a disease of the old. So we should also take note of that. Now, the second risk factor is family history. We are looking at a first-degree relative. That is, I mean, the most important point here. If you have a first-degree relative who suffers prostate cancer, it increases your risk. So for most patients, says that it was estimated that about 20% of patients with prostate cancer reported a positive family history. 20% of those who have prostate cancer would actually give a positive family history. And this point is very important. Now, the relationship is not only as a result of the genetic materials they share, because if you're looking at a first-degree relative, being a father or a brother, it's not only because you share a similar gene, for which reason you are also contracting or having the disease. But they also found out that, I mean, for people with close association, there may also be a similar pattern of exposure to environmental carcinogens and common lifestyle habits. Now, these 2 points, I mean, as we go on with the risk factors, we would realize that they are also important things we need to take note. So it's not only because of the genes they share, but similar exposure to environmental triggers and lifestyle pattern. Lifestyle here, it could be their dietary lifestyle, their sedentary lifestyle, I mean, shared behavior within the family. And it is said that if having a first-degree relative with a disease actually increases your chance by 2 to 3-fold. So that is also very significant. If, let's say, a father had it, your risk increases by 2 to 3-fold. Now, the next risk factor is ethnicity or race. And generally, it is noted it's more common in Blacks than in whites. This is an area still under dispute, and most of the research that came out with this finding actually gave several reasons why this was so. And if you look at the highlighted reasons, we're looking at economic, socioeconomic factors and biological factors. And mainly, if you look at Blacks, as we are saying, I mean, the quality of healthcare among these groups of people is not the best. And again, their inertia to even go to the hospital for general screening is also not the very best. So when you compare these two groups, the white and the Black, most whites would take the initiative to go and screen. I mean, we know some Blacks also have developed very good habits of, doing medical screening, but we are looking at the general population, the proportion of Blacks who would actually take that initiative and realize that it is very small. So in effect, the whites, because of their inertia and their initiative to undergo medical screening, majority of them will get to know of their status. And once you pick it ahead of time at the early stages, remember we said that cancer is very slow progressing. So if you pick it up early, we can even do something about it before it actually gets to the full-blown cancer. So when you look at it in that perspective, then we are looking at, diagnosing fewer cases in the whites as opposed to diagnosing more cases in the Black. So statistically, we find more cases in Blacks as opposed to the white. Another risk is obesity. So obesity is linked to advanced and aggressive prostate cancer and also worse outcomes. And there are reasons to this. Some believe it's as a result of alteration in the sex hormone. And this hormone, we are looking at androgens. And androgen has been seen to positively correlate with prostate cancer development. Now, another reason is also the issue of insulin resistance. It's a common notion that people who are obese seldom exercise. So once you're not exercising, you develop insulin resistance. And this will lead to a buildup of a lot of insulin, which is actually not doing anything. So, insulin helps in the uptake of glucose. So if the insulin is not working, you have a lot of glucose, more insulin will be produced in an attempt to salvage the situation. So you tend to have a lot of circulating insulin. And insulin, we use the term anabolic. Anabolic means it promotes the growth of cells. And if we relate this to the previous slide, we're looking at increase in the number of cells or increase in the size. And insulin is anabolic. So eventually you have an increase in your prostate cells or an increase in the number of the prostate cells. And that will be a problem. Another risk factor is diet. And here we are looking at westernized diet. So if you look at what we talked about, family history, we made mention of shared behavior, which has to do with practices. So I mentioned that we will look at some of the practices, and one of it is diet. Now, it's been found that a high intake in red meats, high intake in dairy products, and high intake in saturated fats actually promotes prostate cancer. So these are meals that, we would indulge. It's more of an affluent lifestyle. But the more we indulge in this kind of dieting, we are actually buying disease. So westernized lifestyle is also a problem. And let's look at the second bullet. Say several studies on migrants moving from developing countries. So developing countries, those are countries at low risk because they probably are not so developed, they are not rich, their meals are more of a local certain type. Now, once they move to the developed countries, what the research found was there was a shift or a drift towards an increased prostate cancer incidence. And a typical example is when you take African American and Africans, now the risk of, or the proportion of prostate cancer cases they had was about 40 times more than in the African group. So we're all blacks, but if you take blacks who are in the US, the incidence is higher, about 40 times higher than the blacks in African countries. Now, it was also not different for Chinese people. They found that Chinese in the US, their rate is about 16 times higher than Chinese indigents in China. So this actually supported this dietary theory, and it's something we should all pay attention to. Other risk factors, we have cigarette smoking and alcohol, and these two elements are implicated in almost all types of cancers that you think about: cigarette smoking and alcohol intake. Lack of exercise actually relates to obesity. And I think in part we've explained it, that the more you are sedentary, the more, and you become, you gain a lot of weight, eventually will lead to insulin resistance. You have lots of insulin and promotes growth of cells. Then the other risk factor is people who have been having recurrent STDs. Now we said the prostate organ can also have infections. So as you get a lot of STDs, being it gonorrhea, being it syphilis, or whatever kind, you are exposing the prostate to repeated infections. And this can induce some carcinogenic changes in the future. So we have looked at the risk factors. So how do we prevent? How can we prevent prostate cancer development? Now, this is a worthy statement. It says there is no evidence yet on how to prevent prostate cancer. However, it is possible to reduce or lower the risk by focusing on the modifiable risk factors. So when you look at the non-modifiable, we talked about age. You cannot actually do anything about age, but all the others are things you can work on. And here we will focus more on the diet, because in as much as certain diets are implicated to have positive correlation with the development, others have also been seen to actually reduce the development of prostate cancer. So we'll look at it. Now, first on our list is a vegetable, broccoli. Now, broccoli, I believe our females who are watching us will be very familiar. Now, it's known to have anti-cancer properties. And some research have actually supported the fact that consumption of this type of vegetable has very good benefits to slow or help to lower the risk of developing prostate cancer. I'll quickly go through because of time. Another vegetable here, we have Brussels sprouts. Now, all these that we'll mention is because of their anti-cancer properties. So Brussels sprout is also another. And I took time to show us the images because at least once you see it and you are familiar, it will help stick them more. There are Brussels sprouts. And the third is cauliflower. Cauliflower also has been found to be very good for the prevention of prostate cancer or reducing the risk of developing prostate cancer. And it's only because of its anti-cancer properties. Now we have turnips. The same reason goes for turnips. So if you are a fan of turnip, then you are on the right path as far as prevention or reducing the risk is concerned. So we have a cabbage. So cabbage also has anti-cancer properties, and this is very common in our household. So, I mean, those who are salad lovers would really have this news, a positive one. Tomatoes. Tomatoes generally has very great antioxidant property, not only for prostate cancer, but for a host of conditions. So unless you have any medical condition for which reason your doctor would advise you to stay off, tomatoes is very good and should be used. Has lycopene, and that is the antioxidants specifically in tomatoes. So we go on. So we have soy. So those who are lovers of soya bean, it is also very good. And the ingredient in there is the catechin, and that has been found to also help reduce the risk of prostate cancer. Again, green tea. So when you take soy and green tea, they all have a catechin, which is very good for the reduction of prostate cancer incidence. Now, certain minerals like vitamin D has also been found to reduce the risk, and selenium. Selenium, we can find it in tubers, in cereals, in legumes and eggs. Vitamin D in Africa is very abundant because of the sun. So these are minerals that have also been found, and vitamins to reduce the risk. So now we've looked at the causes, which we said it's still under studies, but what is profound is our knowledge of the genetic mutations that go on there. Then we looked at the risk. We went through the risks and we looked at certain things that will help modify the risk. We're looking at the symptoms. Although we said at the early stages, you probably wouldn't have any symptom. What would be the symptom if you start manifesting? So that's what we'll focus on. And we'll go back to the diagram we looked at earlier. And this is, a diagram that would explain the symptoms. So we have a normal prostate with a normal urethra, and we have an abnormal prostate with an occluded urethra, which gives no room or space for urine to travel through. So the symptoms, now broadly we'll break or categorize the symptoms into three. We are looking at storage symptoms. So storage, where are we looking? We are looking at the bladder, the urinary bladder, voiding symptoms, and bladder outlet obstruction symptoms. So when we talk about bladder outlets, this is the bladder outlet. That's the bladder. The outlet is the space that should be left open for urine to pass. So bladder outlet, this is a typical example of bladder outlet obstruction. So when we look at storage symptoms, one is frequency. Now, frequency simply means that you begin to urinate at shorter intervals, which you yourself would notice that something really is going wrong. Actually, we know we have physiological causes. When you drink a lot of water, oftentimes you tend to pee a lot. But with this particular one, you can just be urinating even without drinking a lot of water. And for most times, it's best you contact your doctor. The reason being that a symptom here may actually relate to other conditions. For instance, when you talk about frequent urination, I think a lot of people are common with urinary tract infections. So it may not necessarily be peculiar to prostate cancer or prostate hyperplasia. So it's best, you visit the hospital, you have it checked. And more so, when we are dealing with cancer, we put the age in perspective. As we've stated, it's very uncommon in the young. But a symptom is frequent urination. Now, another symptom is nocturia. When we mention nocturia, means at night, you begin to wake up often to urinate. Usually waking up more than 3 times in the night is considered abnormal. So when you begin waking up frequently at night, that's nocturia. It's a storage symptom. Then we have urgency. Now, urgency, usually our bodies are designed such that when you have the urge to urinate and the place you are in is not convenient, your brain, together with the bladder mechanism, is able to hold the urine for a time being. Now, with urgency, you are simply unable to hold the urine. Means it has to come out there and then, and that is a big problem. So there's urgency. The fourth one is, excuse me, the fourth one is urge incontinence. Now with urge incontinence, you have urine leak following a strong sudden need to urinate. Now urge incontinence and urgency really tie together, because with urgency, you are saying you cannot hold. And with urge incontinence, the urine starts leaking. So it tells you if you don't get a urinal within the shortest possible time, you'll probably do the unexpected. So we finish with the storage symptoms. Then we come to voiding symptoms. When we look at voiding, means when you are passing the urine, what are the symptoms that could manifest? Now, one is hesitancy. So here you can feel that you have a very strong urge to push the urine. There's a lot of urine in the bladder, but you go and there's a delay between trying to urinate and the flow actually beginning. So that's hesitancy. You have the urge, but there's a delay. Then intermittency. Intermittency means the flow is not continuous. You are pushing the urine, then it breaks, then resumes again. So there's a break in transmission. Now, the third one for voiding symptom is weak urinary stream. Usually when you are passing urine, there is a certain force that follows the urine. That is, the power. But with people with prostate conditions, realize how you are trying to push the urine, the power behind the flow is very weak. Then we come to straining. Straining. Now, from what we've explained so far, we realize that since there is hesitancy, there is delay, and again, there is that strong urge to pass the urine, obviously you will strain. So it's a very common symptom for people with prostate conditions. So there's straining just in an attempt to void the urine. Then again, there's a sensation. Hello, family. Can we kindly put our audios on mute? I think there is a confusion. Let's kindly put our audios on mute. Thank you. Yeah, so straining to void, we've talked about. Then a sensation of incomplete emptying. Now with that one, you have actually finished voiding, but you still feel there is something within. And your attempt to empty is almost unsuccessful. There is that always the residual volume of urine in the bladder that fails to come out. And you actually sense something is there, but simply not coming out. Then we have terminal dribbling. Now, terminal dribbling for males after urinating, we tend to shake the organ just to expel any residue. But for people with a prostate condition, even after that final exercise, you will still find some dribblings of urine. So often you take off the handy and you realize it's been stained with urine. So that's voiding symptoms. Now the last bit is the bladder outlet obstruction symptoms. And basically straining and for bladder, there's a crossover for the straining. So we've talked about straining already. Then there is pain. That's bladder outlet obstruction symptoms. That's when you look at dysuria. Dysuria simply means pain when you are passing urine. And then here again, for people who are familiar with urinary tract infection, you realize that often when you have frequency, you have pain. I mean, the common thing that will come to mind is maybe a UTI. So if you are even an aged person, say 60 years, and you have this symptom, you don't need to assume, just contact your doctor and you'll be examined. Now, there are other symptoms of prostate cancer that will relate to the spread of the condition. So when we say cancer, we are looking at a malignant condition, a condition that spreads. So it's not only localized to the prostate. With time, if you do not do anything about the cancer, it will migrate or travel from the prostate to affect other structures nearby and beyond. So you can have blood in the urine. Then other symptoms like bone pain. Now, once you start having bone pain, what it means is the cancer cells have traveled to affect what we call the spine. So the spine is the bone at the back. So it means the prostate cells have actually traveled to the bones at the back. That's the spine. Now, once the spine gets involved, the nerves that travels through the spine may also have their share. Now, these nerves, you are looking at the cords. So once the cords are involved, you begin to have tingling sensation in the lower limbs. There are nerves that control urination and fecal expulsion. So you begin to have urinary and fecal incontinence. Then again, the last bit had to do, when we started, we highlighted the importance of the prostate in sexual function. So obviously, once the prostate is affected, its contribution to the seminal fluid would also be cut off. And the integrity of the muscles to contract and give the sperm that momentum would also be cut off. So there is this aspect of sexual dysfunction that may ensue. And more so, once you are having pain at the back, often, I mean, the activity of sex actually becomes difficult. So one of the causes for, poor sex performance and all that often is not even psychological, but mechanical, which relates to pain, people with waist pain and all that. So that is also another thing. Now, how do we investigate and diagnose this condition? We have a series of investigations or modalities. Now, one of them is the digital rectal examination, the DRE. It's a very simple examination technique that could be done in the consulting room. In brief, we'll go to a slide that would explain it better. But the gold standard, if any doctor would diagnose you emphatically on prostate cancer, then it means that doctor might have done a biopsy. So that's the gold standard. I mean, the PSA will give us an idea, but the biopsy, we take tissues from the prostate or portions of the prostate and we submit it to the reference labs for histopathology. So that is prostate biopsy is the gold standard. Then the common screening test we do is the PSA, that's the prostate specific antigen. So that one, I believe after this lecture, a lot more males who are about 40 or even at 40 would come in and have their PSA done. It's one of the tests we do here at Raphal, and it's a very good way to screen the population. Another is the prostate scan. We could also do a scan to look at the texture of the prostate. Because if you look at the picture which we saw earlier, the one with a smooth surface and the one with a bumpy surface, I mean, a simple scan could also help to bring all these things out. Then the other investigations, as stated here, will relate to the extent of spread. So for instance, if you come and you have back pain, I probably will do an X-ray to look at the integrity of the spine. If you come and you have chest pain, it could be that the cancer has spread to the lungs. So we'll do a chest X-ray. If you come and you're having any altered state of consciousness, probably we'll do a CT scan or an MRI of the brain, looking at the extent of spread of the condition. So that is some investigation. Now, this is the digital rectal examination. So with a digital rectal examination, there is a way we position the patient. And as you can see, with a gloved hand, we can go through the rectum, that's the anus, and feel the prostate. So this is the prostate. So with a gloved hand, you can actually feel the surface. The doctor is interested in the surface of the prostate. And there are other parameters we would look out for. But if the surface of the prostate is bumpy, let me use that term, at least gives you an idea. When it's enlarged, you could also have a fair idea. So this, by far, a simple examination technique you can do at the consulting room. It's invasive, and for that reason, I mean, unless it is really an issue, for instance, if you are below 40, say if I'm examining or attending to someone who is 30, I mean, this examination, because of how rare the condition is in that age population, I mean, you will not routinely subject young ones to this kind of examination. But if you are looking at a patient above 40, more so the 50 and 60s, I mean, this becomes a very useful examination. So this is how the patient will be positioned for the digital rectal examination. Now, the patient usually is not exposed. This one is just a diagram, but that's the position. So you lie on your left lateral position, then your knee is drawn towards your chest. So with a gloved hand, the doctor will go in as we saw, and we can actually feel the prostate. Now the treatment modalities, I believe is a little technical, but in broad, there could be surgery. Now if you are confirmed to have prostate cancer, we could perform surgery to take out the prostate. So with a surgery, that's the prostatectomy. It could be just a partial one, or we could do a total prostatectomy. Now, usually after removing the prostate, we follow it up with radiotherapy or a hormonal therapy or chemotherapy. So these are the modalities. Once it's cancer, I mean, it has to be removed, provided it hasn't really spread extensively, for which reason removing it sometimes will give no benefits to the patient. It's worthy to note that the 5-year mortality life expectancy, that's the 5-year life expectancy or prognosis for prostate cancer is very high. So that's to say, if we diagnose somebody with prostate cancer today, we are looking at how many, for instance, 10 prostate cancer patients, how many of them will be alive in 5 years? And it was found that, I mean, for prostate cancer, the percentage was high. About 95% would survive that 5-year period. So that was good, meaning if you catch the condition early, in which case it hasn't spread to the lungs, the bones, the brain, and all other areas, I mean, you stand a very good chance of surviving. Now, the outcome of the therapy depends largely on age and comorbidities. So comorbidities, we are looking at conditions that could bring immunosuppression, like diabetes and all that. Then the type of cancer. Some of the cancers are very aggressive. And so, I mean, the spread is very fast. It takes over the whole body within a twinkle. That's when it starts spreading. Then again, the extent of spread. So these are elements that dictate the outcome. So to summarize, this is what we have discussed within this 1 hour lecture, that prostate cancer in Africa or among Blacks is mostly underdiagnosed. The reason is because we haven't really been keenly interested in going for self-medical checks. It's a culture that is now gaining momentum in the cities, but in the rural areas, it is not so much so, for reasons that we've already enumerated. Most places, as we speak now, don't have cheap compounds. Some don't have hospitals, some no clinics. And so even developing that habit itself becomes very difficult. Now, the incidence of prostate cancer is higher in people above the age of 50. So as we said, 1 in 350, that's if you are looking at the age 50, if you take 350 people, 1 will be confirmed prostate cancer. When you move from 50 to 59, we are saying 1 in 52. Then when you come to ages above 60, that is 6 in 10. So it's something we have to take note. The initial symptoms will be no symptom. So there's this paradox where for some conditions, the initial symptom is actually no symptom. You tend to have no symptom. Then we are also saying there's no evidence yet on how to prevent prostate cancer, but we can reduce the risk. And by reducing the risk, we've talked about certain dietary things we can consider. But also aside the diet, we should also bear in mind controlling our weight is also very important. So weight control is something we should all be working on, and exercising. Also, we looked at obesity and the problems with insulin resistance. Then we also said if you have a positive family history, if you have a brother or a father who suffers prostate cancer, that's a first-degree relative, your risk actually increases by 2 to 3 folds. Now, all these are information for us to become conscious of our health as males and take the good initiative to actually screen. So at this juncture, we want to actually encourage all the males listening to this lecture that if you're above, you are 40 or above, at least for once, you can take this opportunity and have a PSA done to know your status. So we encourage all of us to actually be health conscious and be checking our health, and we should seek early medical care. So these are some of the references, some from lecture notes, some from the World Journal of Oncology. So at this point, we would take questions, that is, if there are any. And all right, so we are in the question and answer section. So if any of us per the lecture we've had, you have any question you would want clarification on, or a contribution, or maybe some experiences you have heard elsewhere, or it could also be maybe a personal experience you could share to give more weight to the topic we are discussing. All right, so thank you.
Can I ask a question?
Yes, you can.
My name is Reverend Olivet Mensah. How many times can one go through the test? How many times?
Okay, thank you for the question. So the test as we talked about, I presume you are referencing the PSA. So with a
yes,
PSA,
please.
yeah, through the, okay, so here, let's put it in perspective. We are looking at different age groups and their risk. So we said, between 40 to 50, if you look at the incidence we gave, for those at 50 is 1 in 350, but increases. So let's say if you have a 50-year-old, a 55, and a 60-year-old, the 60-year-old group would have to actually be doing it very often. So in this case, for them, even looking at a PSA with a biopsy. So if you have a 60-year-old, you do a PSA and you get something suggestive, it should immediately be followed by a biopsy. So, but to cut it short, I would say, I don't know whether we have urologists here who are expert on this, but I would say if you are beyond the age of 40, you can do it every year. Once a year should not be bad. And we also stated that the progression of the cancer itself is very slow. So that's also another thing. So for instance, if you are age 40 and you did the tests this year, and the parameters were all fine, chances are that even a year onward, there wouldn't be any significant change. So if, and I know there are people who do yearly medicals. Yeah, even for some companies that we have, it's almost becoming a practice that every year they take them through medical. So it could be part of your annual medicals. But of course, for the higher age groups, the diagnosis would have to be confirmed. And once it's confirmed, the subsequent PSA will just be used as a marker to see how the treatment is actually going. But for the younger age group, let's say the 40s and above, so 40 to let's say 50, if you are still negative, you can develop a culture of testing it every year. And again, let us also bear this in mind. The PSA is not conclusive of cancer. So although you may have a very high PSA, we cannot use that it's suggestive. So once you do the PSA, it should be followed with a biopsy when there is a strong suspicion of a cancer development. Because we have okay, so Reverend, I don't know whether your question has been answered.
Thank you, sir. I have been answered. God bless you.
Amen. So the floor is,
amen.
Yes.
Good afternoon. My name is Robert Colley.
Yeah, good afternoon.
Yeah, I'm 55 years old. I did the PSA about 3 months ago and everything is fine. But I realized that occasionally when I pass pee, when I go wee-wee, at times it breaks and then it flows, then it breaks and it flows. Does it mean, as you mentioned, it takes, I mean, the cancer grows gradually. Does it explain why when I'm passing urine, it breaks and then comes? That is what I want to know, please.
All right. Well, thank you for the submission. Now, when you have a normal PSA, that means, the prostate antigens are normal. And for starters, there is no grounds for us to say your symptoms are related to either a BPH, that's benign prostate hyperplasia, or even a cancer. So again, we are saying it's not all 50-year-old above males will develop prostate cancer. So there are a section of the population, the male population, who would not develop prostate cancer. That being said, we also mentioned other related conditions with the prostate. So you could actually have prostatitis. Now, I start with the prostatitis. That one is an infection, or it could be a sterile inflammation. But even with that, your PSA will be high. So that's also happening. The prostatitis or the infection, your PSA will still be high. So in your case, I think what I would suggest is that if these symptoms are recurrent, there are several things that may actually be causing it. And some are not related to our topic, but maybe let me just mention one or two. There are people who have what we call urethral strictures. So the urethra, that is the tube that drains the urine. Often from repeated infections, that's urinary tract infections, some people may develop some strictures in the conduit. And so you may end up having symptoms, lower urinary tract symptoms, which may not necessarily be related to the prostate. So here the prostate is innocent, but the tube may be implicated. Now this is just a possibility, but may not be applicable to your condition. So the only advice that I would give is that it's best to discuss with your doctor or urologist so that they take a closer look at what is going on. But with your age, another advice would also be for you to develop that annual habit of checking your PSA and possibly a prostate scan. And I think that will solve the issue. So to summarize the answer, see your doctor. And there are several reasons why this may be happening.
Yeah, Doc, thank you so much. I think you are right. But I realize that it has been a bit. So as you said, there could be. So I'll see my doctor and then I'll find out exactly what is happening. Thank you. I'm very grateful.
Yeah, floor is still open. Okay, let me see. I think we have some questions here. So we still have some little time. Sunset. But then again, there's this myth with prostate. People come in to the hospital, usually young ones, and they will come saying they were either listening to the radio station or in a car or a moving vehicle. Then maybe somebody just came talking about prostate, and one of the symptoms they mentioned was if you are urinating and your urine splits into two, most likely you are having prostate. So this has been a complaint that I'm seeing, a trend in the young ones. And often they will come to the hospital with this complaint and they will request immediately for a prostate test. Now, this myth has to be debunked. When you are urinating and your urine split into two, it has no correlation, especially in the young, with prostate. I mean, when we looked at the anatomy, we'll quickly go back. When you look at the anatomy, you would appreciate that, I mean, the prostate is even far beyond we have the prostatic urethra. So that is here. So that is the prostate and the tube. That is the prostatic urethra. And beyond the prostatic urethra, you actually have the spongy urethra. So we've looked at the prostatic part. Let's go to the spongy. Now the spongy urethra, that's the tube. All these parts is the spongy parts of the urethra. Now for the urine to split, I mean, if you ignore all this section and you implicate the structure, then it's very hard to actually imagine. Because meaning the urine has been able to pass through the structure and the splitting, most likely the cause should be related somewhere here. So for the young who are having either a split or any unusual symptom, I mean, the urethra, that is the tube, has to actually be looked at critically. And as I said, I mean, repeated infections is very common in the young population. So STDs, pure urinary tract infections and all that. And often most people, because of the shyness involved, they would go and get an over-the-counter medication. And it's sad if you don't also meet a pharmacist who would help you and help you well, and just go and get any medication at all. I mean, you end up not treating the infection properly, and any infection left untreated would have complications. So most complications are actually related to strictures.
Bob Frey.
I felt we should debunk. And for the young who are often having the splits, the splitting has nothing, especially for the young, let me say, because we can also embed this knowledge. If you're old, I mean, that one we are saying the risk is high, take steps, and I mean, get your prostate checked. But this information is going to those below 40 who are having splitting of their urine. The assumption that the prostate is implicated has to be debunked. So we are still waiting for any questions. If there are none, then it would be assumed that, I mean, the information is clear enough, and we would be taking the necessary steps to have our prostates checked, especially in this month. All right, I'm receiving information that from Monday, that's this coming Monday, to the end of the month, Raphal Medical Centre will be having some prostate screening. And so let's all take advantage. I mean, you can also spread the news. Those who are not part of this lecture, I mean, if you have a father or a brother, especially those above 40, there's a beautiful opportunity for them to come in and have their prostates examined and checked. And more so for those 50 and above, this is a golden opportunity. So from Monday to the end of the month, it's been set aside for screening prostate. So this month, it looks like we are focusing on our fathers, our brothers, and our grandfathers. I'm very sure the subsequent months would also bring something special for our mothers. So this month is for the males. And so we'll be expecting you, God willing, from next
Good
week.
afternoon, Doc.
Right, there are no
Good
questions.
afternoon, Doc. Good afternoon, Doc.
Yes, good afternoon.
Daniel, I listened to your lectures very well, and I just need to ask one question. If you don't feel those symptoms that you described above, do you still need to go to the hospital for medical checkup since you are 40 years and over? I just want to know.
The initial part of the question wasn't too clear.
All right. I said thank you for your lectures, and I listened to them very well. My question has to, do with the fact that if you don't feel any of the symptoms that you described in the lectures, do you still need to go for medical help since you are 40 years and above?
Yeah. So part of the lecture, the important messages we wanted to drive home, and I believe it's driven home, is that the disease is slow growing. The initial symptom is no symptom. And the beauty of catching it early is that it helps in proper management and better outcomes. So if you're not feeling any symptom and you are 40 and above, it's the right time to actually have your prostate checked. Because once you start having symptoms and it's confirmed, means the disease progression has advanced to some extent. So you could actually have the condition without any symptom. And the only way a doctor can diagnose you would be through the investigation. With that, no doctor can actually look at maybe a 50-year-old and say, I suspect you have so and so. Because the patient himself doesn't have anything. So to answer the question, I think, let me say, it is important that for all ages 40 and above, you should come in and have a check. Most importantly, for those who don't even have any symptoms, because that is the right time to know your status. I don't know if
all right, Doc. Yeah, thank you so much. All right. Okay.
All right. So in the absence of any further questions, we just also want to say the hospital, that's Raphal Medical Centre, is opened 24 hours, 7 days. And we specialists consultation days. Now on Monday, when you visit our hospital,
thank you.
We have the dental clinic. The dental clinic works on Monday in the afternoon. So that is from Monday to Friday. If you want dental service, you can access it here from Monday to Friday in the afternoon. That is from 2. Now, at the same time, those who want to access the pediatrician, on Monday in the afternoon, at the same time, around 2, she is also available. Now, on Tuesdays, we have the physician specialists. So the physician specialist visits us on Tuesdays. We also have the eye specialist who comes here on Tuesdays. So they are all in the afternoons. So if you want an eye specialist on Tuesday, you can access one at Raphal Medical Centre. Now on Wednesdays, those who want gynecological and obstetrician service, you can come on Wednesday in the morning. We have a visiting gynecologist. Also on Thursday, we have one visiting us. Now on Thursday, we have 2 specialists. We have the gynecologist and we also have the orthopedic. Now, the orthopedic time sometimes varies. So on Thursday, you can call in to the facility and we'll let you know what time is reporting. Then on the same Thursday, we have the pediatrician. So the pediatrician, we have her on Monday and Thursday. And on Friday, the skin specialist. So if you want a skin specialist service for any chronic dermatological condition, you can visit us. Throughout the week, there are sections allotted for physiotherapy. So we also have a visiting physiotherapist. All these services you can call in and they would assist you at reception. So in the absence, I think it's 3:30 now. We spent 1 hour, 30 minutes. And I believe the message has been driven home. We want to see all of you next week, especially those age 40 and above, since it's a special month dedicated for screening, so that you all have a fruitful exercise. So God bless you all and have a fruitful weekend. Thank you. Thank you, everyone.
Thank you. God bless you, Doctor.
God bless you too.
We are most grateful.
Yeah, thank you, Doc.
God bless you, Dr. Eshun.
Thank you, Dr. Eshun. May God bless you. I'll come and do my test.
We'll be expecting you.